Now,
Now it's definitely
on the
clear. So
full
we see not
screen, we
only the
have,
mouse.
yeah.
Exactly.
So
Beautiful
it's
pictures are
the same if it is
here.
urticaria, which is superficially, or if it's deeper in the skin, it is called angioedema, which is a swelling of the skin. Both, the one is more itching, the other more disabling or disturbing. But if you take a histological slide, this is what dermatologists do, take a piece of skin, analyze it in the microscope, you don't see much going on. You see that the surface skin is totally normal. And beyond, it's just what we call edema. It's too much so-called water in the skin. This is what makes the swelling and explains why it comes so fast and goes so fast. And urticaria is derived from mast cells. Mast cells are cells which are in everybody's surface. And these mast cells, they can be activated, and you see a very complex picture from a contemporary article. And you can see then that these mast cells, they are loaded with granules, and if you activate them, they release it, and the most effects you know are derived from this histamine. And this most of you know. And then there are surface receptors on these mast cells to activate them. And classically in the old books I've written, it's going via the IgE receptor. IgE is an antibody which is thought to be important to defeat parasites like worms. But if you activate these mast cells, they release histamine, and then the symptoms occur. This is what is in the books. And today I give a brief insight that much more than worm particles or allergens via the IgE receptor can activate the mast cell, but it goes also via other receptors. And we will have in the final talk, we will have some things which diseases look like a complex urticaria, but it's simply not an urticaria. So we distinguish those urticaria and angioedema, which are linked diseases, by asking simple questions. If they have general symptoms like fever, or they feel malaise, or the lesion is lasting for more or less than a day, or is it in the family occurring, or is it drugs that the patient takes? And if we do so, we quite rapidly can distinguish different diseases from urticaria. And what I'm going to talk about today is about the wheals and the angioedema, and the wheals being there for less than a day. And we further discriminate between acute and a chronic urticaria. And this is what we start with. These acute urticaria, virtually anybody on the world can have once in a life. Usually it's linked to infections or with painkillers, so non-opioid analgesics, that's the modern word. In children, food is reported in 10% of the time, so it's not at all so important as expected. In many cases, acute urticaria is not known where it comes from, but the good news, it disappears in virtually most of the patients. And I started with the mast cell and how you activate it, and this is important for the acute urticaria. It can be activated also via MRGX receptors, which are recognizing very different signals, to activate then the mast cell. So totally without IgE and allergens and this. And also infection-derived parameters can activate mast cells to degranulate and finally release histamine. What you notice then on the skin is urticaria. So I mean, acute urticaria is really disturbing for the patients, but the good news is it ends quite quickly. And I guess you joined this session here because you're interested in chronic urticaria. What if it doesn't end in 6 weeks? And then we distinguish between an spontaneous form, so the urticaria comes now and then, just by chance, or it is inducible by specific signals. And this chronic urticaria, it is by far not so frequent. Yeah, the acute urticaria, anybody can be hit from it, but the chronic urticaria affects 1 of 200 persons. And worldwide, there are quite differences, but maybe it's also differences because it depends who reports. But it appears that chronic urticaria is increased in adult females, and in underage patients, it's in male more frequent. The reasons are not totally understood, but autoimmunity may play a role. So if you react against yourself, and some people are sensitive to painkillers, those non-opioid analgesics. Also, a predictive factor to become a chronic case is that it's difficult to treat in the acute phase. So what would we do? We measure in the blood for a blood count, differential blood count, and CRP just to detect obvious strong infections, which may go in via the MRGX receptor or complement receptor, so non-allergic receptors. We screen for major thyroid abnormalities because they are described to be more frequent. We screen for tryptase and serum IgE, which helps us to identify persons which are very allergy prone or to have maybe more mast cells. A skin biopsy we rarely do on urticaria, only if in some cases the patient reports that it is longer existing, a single lesion, for example, on the arm, longer on one place for one day, because maybe then it's not an urticaria, but a linked disease, urticaria vasculitis. What we would like to measure is something in the literature frequently posted as a very distinct marker, like having an allergy molecule against a cytokine, IL-24, or against TPO, a thyroid hormone-associated molecule. So, which is quite surprising, yeah, because it would be an allergy against yourself. What we can do if the patient reports strong symptoms, for example, he has a bad tooth, then we send him to the dentist to make an X-ray from the jaw, or we send him if there's a nasal problem or if there are abdominal pain, yeah, in the tummy, and especially in the upper right, we can ask for an ultrasound from the abdomen in case of an infectious focus there, but it's rare. Some people report pain after or before eating, so then it's a reason to do further diagnostics, but it's not standard performed. Some people totally change their lives, which we cannot understand, and to give back their confidence that it's not food derived. Yeah, some people only eat very specific food, yeah, which is a result we don't like. We can expose them and challenge to see if they react what they usually don't do. So I tried to make categories, yeah. What is chronic spontaneous urticaria if the urticaria persists for a long time? And there the research gave us not the answer, but a good direction. It is making up the box to two different pathogenesis, two main reasons why you get again and again urticaria. The first, more frequent reason is that you are allergic on yourself. This is called auto-reactive against yourself reactive IgE, for example, IL-24 TPO from the thyroid. And those patients, they respond usually quite well to antihistamine receptor blockers, which are called antihistamines, and they are quite widely spread on hay fever, for example. And if that doesn't help, one can try to target this auto-IgE. There is no direct drug, but an indirect agent available. This omalizumab can complex IgE, so also the auto-IgE, and thereby remove symptoms. And by far more rare, maybe it's only prevalent in 5% of the cases, it is an autoimmune disease. Autoimmune diseases you all have heard from, like rheumatoid arthritis or lupus disease, or there are several more neurological diseases or against the gastrointestinal tract. Autoimmune diseases can be mediated not by IgE, but IgG antibodies. This is the class we usually use to defend bacteria, fungi, and also viruses. And if those IgG activate mast cell surface receptors or cross-link the IgE on a mast cell, which is always there, but cross-links it from the outside, then the mast cell is activated, and this is not so easy treated. These are difficult cases, and there we use immunosuppressants. So the idea to suppress the immune system is that those auto-IgG antibodies decline, and then the patient feels better. I don't go totally into the details of treatment, because I guess in the next talks we get a really superior insight in treatment. But what I wanted to state here is that we have a stepwise acceleration. We tried with antihistamines if it works well. If it doesn't work well and the symptoms persist, we updose it until 4 tablets daily. Usually you just take 1. But we know it's safe to use 4, and in some patients they do better. If it is not sufficient, we neutralize these IgE or take IgE from the serum using omalizumab. And if this doesn't work, one can use off-label with permission also more omalizumab. And if this doesn't work, then we at one point make the decision it's an autoimmune case, and we change the concept to cyclosporin. What one should not forget is that sooner or later, this is an unwanted immune reaction which declines on its own. We don't know when, but sooner or later it does. So if one is symptom-free for several months, one can reduce the cyclosporin or reduce the omalizumab and goes all these steps back. So this is about the chronic urticaria, but what also can be is a targeted elicitation of the symptoms. And here, for example, it's a simple scratch. And I don't go in details. Maybe we learn something about this later. So obviously the body reacts against itself if it is scratched or if it is exposed to cold. We had this very strong winter here in Kiel and in Berlin also. And here we see somebody who just was going from the bus to our department and developing wheals. Of course, this is frustrating. And we can measure this. This patient has a problem with cold, which you can see here. If the skin gets cold, you get a wheal. If the skin is warm, you don't get a wheal. Yeah, we can use the test. In those patients, always worth about looking for an infection. Or others. This is a quite sportive man, and he started sport in our department, then developed wheals, quite big redness, and then itchy small wheals. This is an exercise-induced form. Very rare is elicit a warm pressure, light, sunlight, vibration. And a protein contact can be a reason for urticaria. For example, I have to apologize for this typo, that you get something on the skin resulting on urticaria, but it's possible. The numbers are quite bad. Why does anybody respond differently? Because the elicitators are so different. In children, for example, always look for infections, which is rarely important for the adults. In children, antihistamines work quite well. We just have to counsel the parents. What is in pregnancy? It's rare, but we have also to be aware that it seems to be a special case. For the doctors, important. and for the patients also, antihistamines can be used. There's no signal of toxicity, and the reports on second-generation antihistamines like loratadine, cetirizine are without any safety signals and can be used. The updosing should be judged carefully. And we have in Germany a homepage quite giving good information on it. It's called EmbryoTox. It's a governmental homepage. What I missed was the angioedema. You see, this man, he visited our department and having recurrent swellings in the face, totally disturbing the regular life. And what I don't want to go in details what it else can be than an angioedema with urticaria, just without urticaria. But the special thing is this is steroid and antihistamine sensitive, indifferent than if these angioedema are elicited by drugs. What we do is to measure blood. We also look for infection or complement use, and we exclude that a swelling promoting factor, the C1 esterase inhibitor, for a totally different form, an angioedema, is reduced. In those patients, it's always worth to look for vitamin D in the blood, the storage metabolite, because in Kiel, more than 90% of the patients have not enough vitamin D in their blood, and it improves on reconstitution. And of course, we use for regular urticaria parameters. An infection is rarely detected, but if we look in the head area, so dental infections, the teeth, and also in the ENT, so nasal polyps, for example, those patients usually get time until it declines using regular basis antihistamines. So in summary, I wanted to talk about why is not anybody responsive in the same manner. And I hoped that I could get an understanding that the reason of urticaria is different. It can be autoallergic or autoimmune, or directly allergic also is possible. So acute urticaria, we use with antihistamines, and what we don't want to use is steroids. Chronic urticaria is marked as it takes more than 6 weeks. We have a therapy algorithm going with antihistamines, if not sufficient with omalizumab. And if it's not sufficient, we have to go on immunosuppression, for example, cyclosporin. In some cases, it can be worthwhile to look for infections or autoimmunity. So I thank you for your attention.
Thank you so much for a great talk. And I would gladly ask you one question right away. So when the patients, especially when they are new with this disease, when they are still trying to adjust to the life with urticaria, the thing that you tell them, okay, we treat the disease until it's gone. Sometimes it's very overwhelming, very devastating, and patients are still expecting to find the main cause of it. And when we do the screenings, when we do the thyroid checkups, ENT, gynecologist, or dental checkups, if we find any significant or less significant changes, if we find some infection or some thyroid dysfunction, how much can the patient expect that if we control that, if we treat it, the urticaria will be right away gone?
So this is, I mean, I just can talk from my expertise or from my daily work, yeah. And of course, the patients, I mean, everybody is clever. He wants to understand the reason, and in 99%, you're allergic against yourself, which you cannot understand because you wouldn't expect that this is possible. I mean, even in research, 20 years ago, it was not even a thought. And if we, for example, we have cases where somebody said, oh, I have a bad tooth in the upper right, and we make an X-ray, we find it, and the dentist clears the thing. If this was the trigger, it's gone. And we have patients where we treat them for weeks and months, and suddenly there's the focus coming up, and we clear the focus, and the disease is gone. But in the very many patients, it is silent. We don't understand why this overreaction occurs. But what we know is that sooner or later it will end. Yeah.
Yeah, that's already a great news. But for people to wait until that, it's quite difficult, and quite a lot of patients, especially
Yeah.
that are still developing the symptoms, they are coming to the practice most of the time thinking that they have an allergy, and they are completely in detective mode, trying to look for any special trigger that may trigger their
Yeah.
symptoms.
This
And
is what I meant with everybody is clever and smart.
mhm.
Needs an explanation. Human is clever and solves problems. And from my impression, we have sometimes very excited persons which change their regular life inappropriately because they are allergic to themselves. They don't know. And they change many things in the hope it would be better. And for me, it is a chronic disease. Nobody asked, yeah, that you get this, and it is not helping if you get worried or angry about the disease. This is why I guess it's important we have treatments which work quite well. It could be better, sure, but in most cases it works quite well. And sooner or later it shows if there's a simple reason, or it declines if it is against oneself.
Perfect. Thank you so much. There are a lot of questions coming up, and we'll get back to them right away. I would like to encourage all the participants to feel free and shoot their questions right in the question box. But now I'm very happy and pleased to give the stage further on to my dear colleague, Ms. Herzog. So please take your time and take the stage. And so we still cannot hear you. So
Yes.